Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am thrilled to welcome Dr. Peter Catalano to the show. Dr. Catalano is an ENT who served as an associate professor of otolaryngology, neurosurgery, and maxillofacial surgery at Mount Sinai School of Medicine in New York City. He also served as chair of otolaryngology at the Lahey Clinic and chair of surgery and vice president of surgical services at Caritas Steward Healthcare. Dr. Catalano is currently chief of otolaryngology and director of rhinology fellowship at SEMC, professor of otolaryngology at Tufts University, and medical director of research for Steward. He has given hundreds of lectures across the world, contributed to 25 textbook chapters, and authored almost 100 peer-reviewed publications. He has also served as a member of the editorial board of 7 medical journals and as editor of 1 journal. Dr. Catalano is president and founder of the Foundation for Innovation, Education, and Research in Otolaryngology, and has worked with numerous medical device companies to help develop and commercialize minimally invasive surgical tools and techniques spanning 3 decades of clinical practice. He and I have a great conversation, and some of the topics that we hit on include the importance of unobstructed nasal breathing and the consequences of mouth breathing, where the otolaryngology community stands on the topic of pediatric surgery to facilitate nasal breathing, whether or not children will outgrow their airway obstruction, the benefits of CBCT imaging to facilitate diagnosis and referral, the issues with the current medical and dental research and the rampant hypocrisy that exists in academia, whether or not nocturnal enuresis is related to sleep-disordered breathing, some of the innovative surgical procedures that Dr. Catalano has pioneered, and much, much more. Unfortunately, in the orthodontic community and the dental community at large, we don't learn a lot about the otolaryngological side of patient health. We learn the anatomy, but we don't really understand the impact of mouth breathing or nasal obstruction on neurocognitive growth and development, behavior, and cardiovascular health. That is why I wanted to bring a true expert on the show to dispel many of these myths and rumors that get passed around online and at our meetings. Earlier in my career, I really didn't have an understanding of the implications of mouth breathing on all of the factors I just mentioned. And when people brought it up, I didn't really think it was a big deal either. But that was because I didn't know about it. I had never learned about it. And the more I went on this journey to learn and educate myself, reading medical literature, understanding and speaking with sleep physicians, ENTs, the more I began to understand the interrelationship between the way children breathe and their overall health and development. And that is what we are going to spend a considerable amount of time discussing on today's show. So without further ado, let's get on to today's episode with Dr. Peter Catalano. Enjoy the show, everybody. Welcome to Doc Podcast, Peter.
Thanks, Mike. Really pleasure to be here.
Excited to have you. We've gotten to know each other through some conversations we've had, as well as you've been helping me with my project I'm working on with a pretty big article that will address a lot of the issues surrounding mouth breathing. So I appreciate your help and guidance with that as well. And it's been really fun to get to know you. And you've had an interesting career as well. It's had an interesting trajectory, incredibly accomplished in what you've achieved and all of the appointments you've had and all the publications. Tell the audience a little bit, if you would, about, and you can take it back as far as you want. How did you get to be the Dr. Peter Catalano that you are today?
Well, I don't want to bore the audience. They're supposed to be excited by this talk. So I think that the best way to go is, I wanted to be an engineer at one point, so I went to engineering school.
Okay.
And it was always about science and creating things, right? Engineers create things, make things. And I realized, and I did some summer internships in that, and I realized there was no way to really have an impact. I mean, the hierarchy in the corporate world was, I'd watch these people, and it took them forever to get anywhere where they made a difference. And I said, this isn't for me. And one of the guys there that was one of my mentors during the internship said, I applied to med school too. He said, and I chose engineering. He said, but he said, I heard you were doing this medical school thing at the same time. I said, yeah, I applied. I'm doing pre-med and I'm doing it. he said, well, think hard about it, because he says, I love what I do, but it's not for everybody, think hard. I said, I'm okay with where I am, but, think about it. So after that summer of being there and talking to this guy about his choice and all, I decided to apply to medical school and see what happens. If I get in, I get in, and I did. And so I went that route. And everything was just fortuitous. I'm a big believer in fate. And, one door closes, another one opens. Why did I go to this school? Didn't get into the school I wanted to go to, but got into this school. Had I not gone to that school, I might not have been an ENT. And all of that, like it all just dominoes. You look back and you say, wow, if that didn't happen, that wouldn't happen, and that wouldn't happen. And you think it's a misstep at the time. Actually, it's somebody on your shoulder tapping you in the right direction sometimes.
I agree.
So I got very lucky in that respect. I had this hidden angel that was guiding me in ways I didn't appreciate. Anyway, I got into ENT, and I was originally doing what we call skull-base surgery, which is tumors between the brain and the head and neck area. Okay. Orbits, ears, nose, all that area. And I worked with neurosurgeons, and I was appointed, and I had a neurosurgical appointment, an maxillofacial surgery appointment, because we used to disassemble the face and put it back together to get to these tumors, because they were right in the hard spots to get. And I did that for a long time in academic medicine in Mount Sinai, New York. And then, again, the winds of change blew, and I wound up in South Dakota. And my friends in New York were like, are you in the witness protection program? Like, what the hell is you doing in South Dakota?
Fair question, yeah.
Because they didn't know anybody in South Dakota. And so what happened was the chairperson at the institution I was working at changed. And the guy that took over, who was my best friend at the time, believe it or not, I was in his wedding and all that, he turned against me, and it happens. And he just literally attacked everybody in the department in different ways. And in my way, it was something I couldn't stand for that. It was terrible for my career. So I left. And a guy who hired me was this guy who was a country doctor, but brilliant in South Dakota. And he introduced the MicroShaver to otolaryngology. Now, the MicroShaver yes, it was his baby. Wow. And he tells me the whole story about how it came to be. And when he introduced that, because he wasn't an academic, even though he was bright as a whip, he was poo-pooed, he was dismissed, he was not considered serious, but he talked all over the world about this because it was a great new invention. Anyway, I joined this guy because I watched him. I went out to watch him in his clinic, and it was one of the first times in my life where the light bulb went off. Boom. This guy's doing something that I've never seen done before. His technique was incredible. And, surgeons can really, I think if you're a dancer, you can see another dancer. Oh my God, look at that dancer, or someone plays music. You say, wow, that guy's incredible. And I'm looking at musicians and saying, hey, it sounds okay, but the musician knows that guy is really good. It was one of those things. It was an aha moment. The light bulb went off, and I said, I got to join this guy. And he offered me a job. So I went out there, and I worked with him for about 2 years. And we were very close, and we're still very good friends today. He's like a father, best friend to me for years, and he's still alive. He's in the 80s, but he's still healthy and doing okay. In fact, he just wrote a book. Wow. In his 80s, he wrote a book. That's
amazing.
Anyway, then I went to Boston and was offered the chair position at the Lahey Clinic, which was a very nice place to kind of get into administrative work and develop a program that I wanted. And I took his technique there. He taught me this technique, which was designed for sinus sufferers. And when I realized when I got to Lahey, and I was doing a lot of it now, I was really on my own. We had a big program built up, and we were very busy. Patients were coming in and saying, you know what? Thank you very much. My wife said I stopped snoring. Wasn't the intention of the surgery at all.
Yep.
It was for sinus issues, but we started looking at this airway component. This is back in the early 2000s, and noticing that we were getting good results with airway and sleeping issues, even though that wasn't the goal of the surgery. Why? Why are we getting these good results? Like, what the heck's going on? Then in 2009, there's a discovery in Singapore. Now, this is embarrassing for me to admit, but believe it or not, prior to 2009, which is not that long ago, if you were to ask anybody how air flows through the nose, they really couldn't tell you. It'd be guesswork. Nobody knew into an allergist named Deyun Wang, who became a good friend of mine, introduced, using computational flow dynamics, how air moves through the nose, which was a light bulb again. Holy smokes. So at that time, it made a lot of sense because all of the previous nasal surgery that was trying to address sleep disorder breathing or sleep apnea always failed in trying to achieve any improvement in the AHI. And there are numerous reports of different types of, different surgeons around the world even doing nasal surgery and getting lousy results for OSA. So over a 10-year, 15-year period, it became basically the standard was don't do nasal surgery for OSA. Okay? Now, I was getting different results. And I'm saying, what's happening here? So I looked at all the other reports and realized they were doing the wrong surgery because they didn't have Deyun Wang's airflow model.
Wow.
So if you want to find a robbery, what do they say? They say follow the money. Well, if you want to improve the airway, you got to follow the airflow. So the airflow goes through the nose in an arc. It doesn't go straight through. And everybody was doing septoplasty and inferior turbinate reductions as the gold standard treatment for nasal issues with OSA and sleep problems. And they're missing all of the airflow. The airflow goes superior. It goes right between your eyes. That's where the maximum airflow goes. And it goes there for several reasons. But again, until Deyun Wang showed this to us with little beautiful diagrams of airflow, nobody knew. Now, a lot of people still don't know that. A lot of my colleagues still have no idea about this. And when I show pictures of it, because I have nice slides from him, and a lot of people are sitting there with their mouth open like, huh? What do you mean, huh? That's like, you should know that by now. It's almost 20 years later. Almost. Anyway, so with that model, I started to then realize with the airflow model, looking at the nasal anatomy, what's in the way? What really should the targets be for improving airflow? There is an inferior pathway along the inferior turbinates, but the majority of the air goes superiorly. Now, this is where we get into the problem of my colleagues and nobody wanting to do airway surgery. The area between your eyes is where the sinuses communicate with the nose. Okay? And there are sinuses that are literally in the way of airflow. And so the Chinese, once this computational flow dynamics became a hot model to use, which is a very labor-intense and expensive model. So it's not been something that a lot of people have been able to do because it's not something you can do on your own. It requires a lot of computing power and a lot of time and effort because you have to look at a CAT scan. It could be 120 slices, could be 500 slices, right? Where you got to go slice by slice by slice with the airflow and kind of map out like a loaf of bread from the beginning to the end of the loaf. So that takes a lot of time and a lot of effort.
Yeah.
But if you do it and you have a team, which Deyun Wang did, he had a bunch of postdocs in his lab, he was able to show this and show it worked. And then what you do is you take away some of the anatomy. You take a head, you take away some of the anatomy, you do the flow study again, you see what happens, et cetera, et cetera. So the Chinese realized that if you took away something called the uncinate process, and the anterior ethmoid bulla, which is, if we had pictures, we can show you. But there are sinus structures right between your eyes. They're safely located. They're not really up by the eyes. They're safe in that they're kind of toward the center part of the airflow stream. But if you take those out, you get between a 15 and 20% improvement in airflow, just with those two things. Now, that's a big deal. Okay. So we said, wow, just by taking out those two little structures, which have no consequence, no untoward effect on anything else. And actually, like I said, it helps sinus sufferers quite a bit when you do that. Also, major change in airflow. So that was a big deal. Then there were other reports that came out, which also from the Chinese, that showed that, we're always taught that the sinuses have these openings in them to ventilate and drain the sinuses. Key word there was ventilate and drain. Now, we know it's drainage. because the sinus have to have a way to get mucus out into the nose, right? That's where your flow comes from for your saliva, etc. So you have mucus coming out of your sinuses into your nose, and that cleans the nose, etc., etc. And there's this mucociliary pathway that pushes everything from the front of your nose to the back of your nose. You swallow it and you recirculate the saliva all day long. Like 2 liters a day that you're swallowing that way. So it's a pretty active system. But we also were told that ventilation was key. And so previous surgeries were making big holes in sinuses to ventilate them. Okay,
I have a lot of what you've been describing in my own sinuses from 2 sinus surgeries that I went through in about 15 to 20 years ago. So yeah. Sorry, go ahead. But as you're saying this, I'm sitting here with this smile like, yeah, you're describing my anatomy pre Dr. Wang's discovery.
Yes, and so many doctors made the mistake of making these big holes in sinuses to ventilate them. Well, when the studies came out showing that when you inhale and exhale, the sinuses do not ventilate at all. That's a huge change in philosophy. So if you don't have to ventilate a sinus, then the big holes aren't necessary. And so what people were doing by making these big holes, they were causing more trouble than they were actually solving.
Disrupting the flow.
Absolutely. They were making holes because the cilia are pre-programmed to go out your sinus drain that you're born with, your birth opening. You make another hole somewhere else, it's not programmed to go out that hole. They were doing it for ventilation purposes, but it screws up the other problem, which is the other function of the sinus, which is drainage. So now the drainage is impaired. So now you get more sick. You get sicker more frequently because your drainage is screwed up. It's not better.
That was worse. Me.
Yep. So, anyway, getting back to the airway piece. So if you follow the airflow, you realize where you have to go with targeted directed surgery. It's minimal surgery. It's targeted surgery. It's anatomically correct surgery. And it's very safe because of that. You're not making these big holes. You're not tearing tissues out, etc. There are structures in your nose also that are responsible for warming and humidifying the air. We mentioned the inferior turbinates, but there are upper turbinates as well. These upper turbinates oftentimes are pneumatized. They have air pockets in them. And these air pockets are called concha bullosa. Sometimes these concha bullosa are huge, like the size of a peanut, like a Mr. Planter's double peanut or an almond. And sometimes they're small and inconsequential. But when they are big, they can literally be super obstructing. And you can't see them with your scope. All you see is a mucosal line structure. You have no idea that it's pneumatized or hollow or how big it is. Everything in the nose is all crammed in. People think, you have this beautiful view like you're looking at a painting in the Louvre. It's not like looking at a painting. All you get from looking in the nose with an endoscope is, what does the mucosa look like? Is it look allergic? Does it look erythematous? Is there pus? Is it crusted? Is it dried out? That's what you're looking at, okay? You can see in the anterior areas if there's significant obstruction by septal deviation or something like that. But you really cannot tell a concha bullosa. So that goes to your CBCT. Without a CBCT, it doesn't have to be a CBCT. It can be any CT of the sinus. You need a roadmap as to what that anatomy is. Because without that, you cannot sit in front of a patient and say, here's your problem. Many parents, so you go back to the CBCT piece, the pediatricians freak parents out about radiation exposure in kids by using x-rays. And CBTC is extremely low radiation exposure, which is why it's great technology, right?
Especially the low dose machines, the one that I put in my office in 2014. I mean, it's effective dose. There was a 2013 study in the AJODO that talked about the fact that the effective dose of that machine is essentially like 17 microsieverts in a young child. A 2D Panorex at that time was like 20 to 25. Now I think it's maybe they have some machines that compare with that. But still, we're talking about comparable radiation to 2D imaging.
And you get so much more information.
Yeah.
So some of the parents who were very hesitant and somewhat reluctant because they heard about this, I said to them, in the office, listen, you'll see what I'm talking about. We really need the CAT scan. And almost all of them, I explained to them the low radiation, all the stuff we just talked about and the safety of it, and they'd go ahead with it. And then when they saw the scan, now they didn't know what they were looking at, but as I explained it to them, many of them were reduced to tears that, oh my God, nobody showed us this. Nobody told us this was the problem. Mm-hmm. And we had kids who were mouth breathers, who when you're a mouth breather and you're 6 years old, you can't eat right. Because you can't breathe through your nose. You have to breathe through your mouth, and you can't eat if you breathe through your mouth, right?
Yep.
So they don't want to eat.
I hear that. I always hear that all the time. They don't.
Exactly.
They ate better after I performed early interceptive treatment. Again, like you were saying, when you were doing these earlier procedures, you didn't know the net effect it would have. I'm like, okay, I guess maybe their tongue has more room. Maybe they were going to bite their tongue. I didn't know. I'm got embarrassed to say it now, but I empirically was just kind of like, I'm hearing this a lot. Like they're saying, my child could. I have a dad. One dad. I used to do little interviews. I'd take my phone out when parents were kind of raving about it, and one of the dads literally said, like, she couldn't eat sandwiches. She couldn't. We'd have BLT. She couldn't bite them and chew them. Ever since you've done what you did, she can now chew food. And again, so it's very interesting that you say that.
Yep. And the kids, so once you see that, and the parents are like, oh my God. And then the kid would be like, see, Ma, I told you, you're picking on me for no reason.
Yes.
And the mother's in tears. She's, oh, I'm so sorry. It's like a whole big drama in the office over the x-ray that they are blown away by. I mean, it's black, white, and gray. It's three colors. It's so easy for them to understand once you sit down and show it to them. Yes. And they're like, and I have a normal that I always show them the normal next to it.
I love that, yeah.
Here's the normal, here's your kid. And they're like, I mean, you don't need to be a rocket scientist. Everybody can see the difference between this image and that image, right? And it's very simple. Yeah. And so that would make them really understand what we were talking about and what their child, or even themselves, if there was an adult, what they were dealing with. And so you didn't have to say much after that. Mm-hmm. They said, when can you fix it? Yeah, agreed. When can you fix it? Because it's so obvious. These aren't more, I mean, these people are usually very obvious. So anyway, so the surgery that goes up between the eyes, because it involves the sinuses, gets us into a insurance dilemma, which is where the problem starts. See, in medicine, everything is insurance related. Mm-hmm. In dentistry, rarely is that the case. Mm-hmm. You can do whatever you want. Most of it's fee for service. There might be a payment that comes from insurance, but it doesn't dictate for the most part, unless you're doing jaw surgery, which is really medical surgical, what you can do in an office setting with orthodontics or expanders and all that kind of stuff. In medicine, totally different. So
interesting for 1 second, Peter, if I could interrupt you. You're 100% correct on that, and I agree. One little caveat, though, in orthodontia, one of the reasons why a lot of orthodontists won't do phase one is because they say, and I've heard this openly said from everyone from friends and colleagues to the AAO president, that it will, and it's been published in our journals for over and over again, you're going to waste their insurance benefit and they're going to need a second phase anyway, and then they won't be able to afford a second phase. They say it openly all the time. Not that it's not valid, not that the patient couldn't benefit, although some people do say that as well. And I always say, if you're not doing it properly, of course it's not going to work. But if you know what you're doing and can do early interceptive care, you can transform the craniofacial growth and development, and many times breathing, of these patients. But we literally look at it and say, just like you're saying, well, that's not the age insurance covers you to treat. Or if they do, you're going to use all the benefit up so they won't have any later. So the parallels, it's just unreal as you're saying this. I'm like, oh my gosh, talk about letting reimbursements drive the care.
Well, but it's worse than that. So the ENT surgeons, so I'm back up a second. So there's a standard of care, right? Medical legally, there's a standard of care. Mm-hmm. And the standard of care right now is that you don't operate on the sinuses for airway. You do not.
So that's still the standard of care.
Oh, yes. There has to be sinus disease. So now you got a situation where you've got clearly a reason to operate on that sinus that's not sinus related, but is related to, and a bigger issue, which is the quality of life from breathing is much more important than the sinus. Mm-hmm. Not to belittle it, but the point is, it's a significant factor here. Mm-hmm. And insurance won't cover it, but medical legally, you're now out on a limb. And so a lot of
is this just for kids or is this adults too? This is kind of...
Oh, kids gets worse.
Okay.
We'll get into kids in a moment.
Okay.
That's even another kettle of fish. Uh-huh. So you can't take a 40-year-old guy and do an airway operation on him without getting potentially exposed and into some kind of potentially trouble. So a lot of ENT guys are afraid to do it. Now, if there happens to be concomitant sinus disease, septal deviation, okay, but the septal deviation is not a sinus issue. You know? So that's one issue. Now, with children, the golden rule has always been previously never operate on anybody under age 16. Never under age 16, because sinus surgery, septal surgery, if you do it under age 16, listen to this. This is going to be very important. Will, I'm cracking up because it's so crazy, will restrict craniofacial growth.
Come on.
Will retard craniofacial. Yes. And
what are they basing that on?
So there were some models done in ferrets in the 1980s. True story.
Goodness.
And if you operate on a ferret septum in the 1980s, you would stunt the growth of these baby ferrets. However, the technique done for septoplasty back then was totally different than the technique done now. So a cosmetic guy named Bernstein did septoplasty in ferrets the correct way by preserving what we call the mucoperichondrium and mucoperiosteum of the septum itself. And if you do that, there's no change in craniofacial growth. No restriction in craniofacial. But that came out after. It was already dogma, don't touch a kid under age 16.
Wow.
And so no one read the second article 5 years later. They only read the first article, and everybody ran scared from touching kids. So when
Isn't it amazing, just as a little aside, on how these poorly conducted and flawed studies will permeate our culture? I mean, look what just came out on women's hormone replacement therapy, right? Yeah. And all the women that have suffered for the past 25 years, or maybe a little less, I guess, for that abysmal study that has caused exactly your point. I heard physicians say all the time to me, friends of mine, that study was flawed and they were doing it off label because they knew that it was helping their patients and not increasing the risk of breast cancer. And then finally now some common sense has prevailed to look at these things again to say, like, let's dig into the science and the literature and reevaluate this. But Peter, think of all the patients, both on the otolaryngological side with what you're saying, right? That they're because of these sort of quote unquote standard of care. And then in this case, in the hormonal side with women that have suffered because of these dogmas.
Well, this is a problem with academic medicine. Remember that the mentor of mine I told you about, who's in his 80s now, Dr. Setliff? Of course. And he said he wrote a book. On that book, he has a whole chapter devoted to the flaws in academic medicine because he was a victim of that. They tried to put this guy off the pasture because he wasn't part of the club, even though he had...
I know the feeling.
And so he transformed sinus surgery from a very aggressive procedure to a very safe, targeted procedure. And it wasn't the academic's idea. It was his idea. And because he was an academic, he was then a target of the academics. And he fought this for his after this introduction of the shaver for years after that. And that's why he wanted me to join him. He said, you have to join me. You're an academic, because I was an academic. He says, I need an academic in my practice because no one's going to listen to me if I don't have an academic. He said, you can write the papers, you can do all this stuff because they'll listen to you. You're an academic.
Boy, that clinical academia divide that rift is so big and wide. Oh my goodness.
Exactly. So in the pediatric world, like I said, you weren't allowed to do that. Now, so I was doing all these kids, and I get a letter from a big insurance company in New England. And they say to me, listen, we have these 25 children that you operated on. This is against our policy. Our ENT advisory board said that this is not allowed. This is unethical behavior. And we want to know, number one, how did you get these cases approved? And number two, we want you to answer these claims. They had like 5 different questions of what are you doing, blah, blah, blah. So I said, okay, clearly somebody alerted the insurance company that this was happening because they didn't just pick it up on their own. I guarantee that. So I said, great. Luckily, at that time, we had enough data. John Walker, who was Liz's dad, who you just had on about a week or so ago.
Sure. Yeah.
Her dad and I worked together for about 15 years. And he's the one who taught me all about orthodontics, which I knew nothing about. He came to me as a patient. He had apnea. And his primary care sent him to me when I was doing this MIST stuff. And he said, go see this guy. He's going to help you. So John came in. I didn't know much about John at the time. He said, I got apnea. I went over a scan, everything. I operated on him. And he was like a new man. He said, I'm going to keep you very busy. We're going to work together. I didn't know what he was talking about because I didn't know anything about the dental world because nobody in ENT does. And John taught me orthodontics. I taught him rhinology, and we became a great team. And so I said, John, we're doing something that has never been done before. All the data is against us. So what we need is data. Everything we do from now going forward has to be with an eye toward collecting data to prove our point. We knew anecdotally the results were great. We saw these kids. We knew it. We said, but we got to collect data. So we started collecting data. We did a bunch of studies. We started publishing them. Then this issue came up with the insurance company. So I got all my stuff together, got all the stuff elsewhere in the literature, put it all together, and sent them a nice packet of information. And about 2 months later, I get a letter from the insurance company. Dr. Catalano, thank you for your response. Based on the information you provided, we are changing our policy with respect to pediatric sinus surgery.
Wow.
And the ENT advisory board agrees with our decision.
Wow.
Thank you very much. That was huge. It was only one carrier, but it's still, it was a huge, otherwise you get barred from an insurance company, you're screwed.
Yeah.
You know, in our world, you can't. That's like basically going to jail. But to go a step further, Mike, believe it or not, now we have all this data. We're doing really well. We feel really confident. Do you know that there were people out there, and they're physicians for sure, who have pushed patients to try to take my license away?
I believe it.
And I've had 2 or 3 inquiries from the Board of Registration in Medicine in Massachusetts about my licensure based on not surgery, just consultations on children, just consultations where they go for a second opinion. They say, he's a quack, he's terrible, you can't go there. Scare the hell of them. They're right to the Board of Registration. Investigate this guy. I hear he's doing unethical surgery. Now I've got to go and give him all this. This happened 3 times. Each time I was vindicated, but 3 times tried to take my license away, and 1 time tried to get me in jail with the insurance company. So this is a robust, significant hurdle in otolaryngology, and people know of it, my colleagues. So in addition to that, the other hurdle they have is medical legally in children, statute of limitations. In adults, the statute of limitations for surgery is 3 years. Something goes wrong, you have 3 years in which you can sue the doctor. With children, it's up to age 18 or 3 years, whichever is greater. So if a kid's 17, you got till they're 20. If a kid is 12, you got 8 years, or 6 years. Yeah. So young kids, they're afraid to touch them because the parents can come back 8 years later and said, you caused, this happened to obstetricians. I don't know if you're aware of this. Obstetricians have the highest malpractice in all of medicine.
I did know that, yeah.
Because of the statute of limitation, which is until the kid's 18 from birth. And there were people who literally sued their obstetrician 18 years later because the kid didn't get into Harvard. They said, because your delivery screwed up my kid's SAT scores, he didn't get. This is true.
Yeah.
This has happened. So, my colleagues say, listen, Pete, I'm busy with what I'm doing. ENT guys, luckily, and most of them are very busy. I'm busy with what I'm doing. You're asking me to do a surgery I know nothing about. I don't know how to operate on kids. No one taught me how to operate on kids.
Yep. Oh my God, the parallels are insane.
Yeah, of course. Something goes wrong, I'm on the hook for years for that. And yet I don't have the data or the experience you have to stand on should someone come after me in my community. They'll just ride me out of town.
Yeah.
So you're a dentist or an orthodontist, you want to work with an ENT guy. These are the problems they face.
Yeah.
Even though there's a lot of data out there now supporting what we're doing, and there's been, like I said, challenges to this have been completely controlled and overturned. People say, I'm not you, Pete. I don't have that background. I don't have that experience. I don't have those publications and blah, blah, blah. But they're still there for them to refer to.
Yeah.
And so this is why most of the ENT community won't pick up this area. That in their mind, they were never taught it. They don't believe that they have a medical legal standing, and they're afraid they're not get paid for it, et cetera, et cetera. So, I feel sorry for all of your colleagues out there. So I do it. I still work down here. I'm not as busy as I was up there on purpose. I do select things, but because people call me and I say, how can I turn these people down? Like, they're really symptomatic people. Mm-hmm. And so like dentists and colleagues who know me say, would you see this person? Would you see that person? Et cetera, et cetera. So I do a lot of telehealth stuff and we do x-rays and we see who's candidate. I'm going to do one this afternoon with a lady from South Dakota, in fact.
Interesting. Yeah.
Because they find you because they can't get care in their community for these reasons. So, changing in ENT, in medicine, coding, procedural coding it controls everything. Yeah. And if the codes don't allow a certain intervention, there's no such thing as off-label medication is one thing. Off-label surgery doesn't exist really.
Yep.
And so there are what we call uncoded procedures. Mm-hmm. So if you do something that there's no code for, you can try to get paid for it. Chances are you're not going to. So most people aren't going to take that risk. They're not going to do that.
Yeah.
So I feel terrible about the situation. But despite the fact that we have so much data, we have so many years of history now, and really compelling information that this is the right thing to do, the problem doesn't lie so much with the doctors now not believing it. It's the system that's against the doctors who even want to try.
Yeah. Oh my, it's so fascinating. And there are so many parallels to the early interceptive orthodontic world, whether it's being done by an orthodontist or general practitioner or pediatric dentist. It falls under the same auspices because of the fact of the insurance and the liability. And there are people in my community who say that's a breach of standard of care to go in and start treating these kids young, even though we have all the data on the neurocognitive impacts, the behavioral impacts, the cardiovascular impacts, right? The craniofacial growth and development impacts, which I do want to get your thoughts on the Harvard study in monkeys breathing in a second, because it's just become a hot topic, but we'll come back to that. But they dispute these years of data. And I can go back to the early 1900s and show how dentists were speaking at conferences, the rhinology conferences, they called it back then. And they were talking about the importance of detecting these issues young, and conversely, physicians speaking at dental conferences to coordinate care for these young mouth-breathing patients, and that they should be treated by 3 years of age. And I showed a colleague that recently in one of our online study groups, and the colleague's response was, now we're going to start taking advice from over 100 years ago. And I said, I said, what do you call the molar occlusion when a patient walks in? Class 1, 2, or 3. When did that come about? Over 100 years ago from Edward Engel. That's why it's Engel class 1, Engel class 2, Engel class 3. I said, so are you picking and choosing the things they were right about or the conventions that they understood and didn't? And we could go on and on about the hypocrisy. But my point is there's always an answer as to why they don't want to do it. But it comes down to what you just said. They're fearful because they don't know how to do it. They weren't taught. They're fearful of liability, and they're fearful that they won't get reimbursement or it will affect the benefits. And as you said that, the parallel are just insane. Now, a couple areas I want to go, actually a bunch of areas. I love what you just explained, and thank you so much for giving us that chronology of not only your evolution to get to this point, plus how that intertwined with the field. One thing I want to highlight too, so agree with, you said the hidden angel on your shoulder tapping you. I couldn't agree more. Before we started recording, I was updating you on me with this pediatric residency in Naples and just how it happened in this weird way. And now I'm going to be able to have such an impact. And so I completely agree with that. CBCT, and then I want to go from there into adenoids. So CBCT is still actually a very controversial thing in the orthodontic arena. I don't know why. I have theories. I can't say for sure that I know 100% why. My theories are it's hard to integrate them into our practices, meaning, because I did this in 2014. When you go from 2D imaging to 3D imaging, you have to change your diagnostics, your protocols, your team training, your data storage capabilities. If you have multiple office locations, you have to essentially buy one of these very expensive machines for every office, or else you have one office running on one system, one office running on another system. You have to have protocols to get the 3D image into 2D, which you can do through the software, but you have to build systems for it for your team. Because insurance companies can't open a 3D scan. You can't send it to the insurance companies. And even referring docs oftentimes can't always see the 3D images if they don't have the right technology. So there are logistical challenges to the implementation. Fine. people don't seem to talk about that. They seem to just talk about the fact that, it's too much radiation. Well, we already dispelled that. That's not true. The other part they say is, well, there's too much information. And I hear that a lot from my orthodontic colleagues. And yeah, it makes me shake my head. But I had a director of an orthodontic program tell me that there is no need to look at 3 dimensions of a developing face for anything other than tooth impaction, craniofacial care, or orthodontic surgery. And I said, why wouldn't I want to see what's going on up in their nasal passageways and sinuses and pharyngeal airway? And he said, well, that's what the ENT is for. And I said, okay, let's go with that for a second. He said, and nasal endoscopy is the gold standard for detecting adenoid hypertrophy. And I said, fine. I said, I'm not my place to disagree. I understand that is what's perceived to be the gold standard, although, your point again on the limitations in the nasal cavity are certainly well taken. I said, fine, let's say for adenoids, gold standard, not going to argue. You're telling me that every ENT that sees a 5, 6, 7-year-old kid is putting a scope up their nose?
No way.
No way. And he said, well, that's not what we can control. I said, so we're just going to turn a blind eye? We're going to act like we don't have a role in this? I said, I did this in private practice for a long time. The ENTs loved getting my CBCT images. Loved it because they could then see things that they couldn't see and didn't have to even consider putting a scope. I mean, a lot of them will look with a rhinoscope. They'll kind of turn the nose up, but they're not going deep up in there in a young kid. So it created, and as you talked about the relationship that you developed with Liz's dad, John Walker, that's exactly what happened with myself and a pediatric ENT in my community in upstate New York, where I was, Jason Mouzakis, who will eventually be coming on the show. He's now an admin in the hospital, but we had the same thing. I would pick his brain on these scans. That's why they recruited me to be on the cleft craniofacial team up there, because when I would refer a patient to him, I would send him a copy of the scan. And he was looking at these scans like, who is this guy taking these 3D images? And this is back in 2014, 2015. He's like, this is amazing. We've got to get this guy on the team. He loved it. It helped him so much because he didn't have to go up there with a scope, and he was one that did it more often than not. He did. But anyway, so the interrelationships and the crossover are so important to highlight. So I guess the question would be kind of 2 parts on the CBCT. What would you say to the orthodontists who say we don't need them? And then the second question is, why don't ENTs have these things in their offices?
So I think one of the things I've noticed with the CBCT in the ortho office, and this is something that I think you guys should consider, you guys meaning the orthodontic group, is no one teaches your team how to look at the entire image, to look at the sinus and the airflow pathways. In fact, many of the CBCTs I see are cut off.
Yes, it drives me nuts. I agree.
They cut off just around the orbit level.
Yeah.
And so you're missing, like I said, that upper part. That's very important.
Yep.
And so I think if they knew the value of all that they were looking at, they would say, you know what, I can see my dental stuff, but if it's very easy to teach them how to read a CT.
It's not hard. Jason taught me in like 10 minutes. I was like, oh, got it. Okay. We study the anatomy. It's not like we don't know the anatomy. We just have never looked at it that way.
Exactly. And you know how many times, by the way, we have found some tumors in kids, by the way.
Yep.
Hidden tumors.
Yep.
Luckily benign, but nonetheless, John and I found 2. And, but the kid never knew they were there. I mean, big blocking things, never knew they were there. Kid just accustomed to it.
Yep.
Anyway, so you get to see so much more of what the issue is with the child, what's causing all the ortho issues that you're seeing, the dental issues, by looking at the whole airway. Like you say, you can see the adenoid, you can see the sinus areas, you can see everything you want to see. But I don't think they're trained, which is why they kind of cone down the view a little bit too much. So if we open the view and taught them more about what to look for, I think they'd say, wow, this is a really good case to send to so-and-so or so-and-so. And it's going to help, like you said, help your colleague realize, hey, there's something going on here. Okay. So if you had a kid with a huge, concha bullosa and a septal deviation and adenoids, that's a doable case. That has insurance coverage, that has criteria, and that has medical legal, coverage. So those are something that people could do and help that kid tremendously just with those.
I did it many times. Yeah.
Yeah. So, there is a lot to be found there that the ENT could benefit from as well, from doing that. And it reduces, the radiation they're going to get in a conventional CAT scan is much more than the CBCT.
Oh my gosh,
If ENT sees
100 times more. Yeah,
it's going to exactly. So why not do the CBCT?
Yeah,
So I think there's a lot more information there. It might not be harnessed fully for the dentist or orthodontist to know how much they can really gain from it. Mm-hmm. And we can talk more about that. But there's some ways to teach that. In your community. Mm-hmm. The second piece on the CBCT was
with the why don't ENTs have them?
Yeah, so many of them do. So I did.
Oh, okay.
Yeah, many of them. All my colleagues that I know that are in private practices, most of them have them. They don't have CBCTs; they have the equivalent of a CBCT. Okay, but it's a portable CAT scanner in their office.
Okay.
Looks just like a CBCT, and they're made for ENT, but they're the same thing, whether it's Carestream or Zoron or any of these. They all do the same thing. Many of them do, and they do those if they're good at what they do and they're good rhinologists. They will have that. Now, if they're not a rhinology-focused practice, they do general ENT. They may not see the utility in spending the money because they do thyroids, they do parotids, and you're not going to use it for that. Mm-hmm. It's really great for just the airway stuff we're talking about. Mm-hmm. You have to use contrast in there, and sometimes you got to use contrast for other tests. So if an ENT is a general ENT and does occasional sinus work, unlikely to have a CBCT or any kind of imaging. But if they're rhinology focused, which is the world that I live in, these guys all have CAT scans in their office.
Mm-hmm. Okay. All right. Appreciate you explaining that further. Why there's still debate in the orthodontic arena why nasal breathing is important. And there was a recent article which kind of became the impetus behind our interaction on the article that I've been working on. It was in June of the AGO-DO. It was a special article that the gentleman who wrote it said he was asked by the publication to write it, and he said, I was asked to write this editorial. So indicating it's essentially representative of the views of the publication. And it literally mocked anything and everything to do with those who think mouth breathing is a thing that we should be concerned with. And I know you've read it as well. So I know a large part of our audience has probably read it. If you haven't, I'm happy to put it in the link in the show notes. First off, before we dive deeper into that, one of the things that was said in that article and claims that was made is that the Harvold studies, which you and I have spoken about, amazing studies done, and just for the quick refresher for the audience, most probably know, but done in the 70s and published into the early 80s at that point, AJO, before they added the DO. And it was by Harvold, who had looked at purebred rhesus monkeys, and he evaluated their changes in craniofacial growth when he plugged their noses with silicone plugs. And he looked at them at 6 months and then 2 years, and then he removed the plugs and monitored the growth still. And he found that the monkeys who had plugged noses grew with longer, more vertical faces, narrower arches, more severe malocclusions. And when the plugs were removed, that growth started to normalize again. And this gentleman who wrote this article said that those studies are completely invalid because monkeys are obligate nasal breathers and therefore have all sorts of excessive adaptations when you plug their nose. To which I thought, if they're truly an obligate nasal breather, they would die if you plugged their nose. And I actually looked it up, and it really is only horses and rabbits that I found that are true obligate nasal breathers. Monkeys are preferred nasal breathers, as are humans. So you helped me understand that because it was one of the items of feedback that you provided in when we were circulating and talking about ideas for this. So could you elaborate on just that a little more, and then we'll go into a little more about why mouth breathing is something we should be concerned about?
Sure. Well, first thing I want to bring up, and you mentioned it before also when you talked about history 100 years ago. Mm-hmm. Harvold was 50 years ago, right? But how did Harvold, why did he decide to do that study? Why did the doctors in the 1910s know there was a problem with the nose? Because these people paid attention to their patients differently than we do because they didn't have any other tools to do it.
Their intuition,
looking at the patient, comparing patient to patient, subtleties in the way the face looks, the way the mouth is, the way the tongue. They were seeing patterns developing They didn't have CAT scans. They didn't have x-rays. They didn't have medicines, right? They were observing. I mean, this was back, I sent you, I think, the link.
You
Hippocrates.
did? Yep, Hippocrates.
Said, listen, these people who have these nasal problems, have ear problems, it's all linked, okay? And so it's from observing people. And you have people who don't have the problems and people that do have the problems. And you can start to parse out who is likely to have a problem. So Harvard was watching his orthodontic patients, saying, these are different than my general dental patients. These people have these anatomic issues that I'm noticing, these facial features, the bruxism at times, etc. And I think it has to do with that they can't breathe. So he deduced, hey, let's do a study and see if we're right, which is phenomenal. And he did the study. Now, to your point, we humans, just like monkeys, prefer, and there's a lot of physiological reasons why breathing through your nose is preferred. Okay, and that's not refutable by anybody, I don't think. We have evolved to the point that we do have a backup system, thank God, which is our mouth. But it is not the primary. You don't eat through your nose, and you don't breathe through your mouth. It's reversed, right? You're supposed to breathe through your nose and eat through your mouth. And that's really the way it's supposed to be. We have a backup because we don't want to die. So the brain and the body has evolved to say, okay, this is the way you're supposed to do things, but just in case you can't, we've got this backup. Harvard's study should have, think about it. I mean, it was a sentinel study. At that point, everybody on the planet should have been like, oh my God, this guy's figured it all out. But there was no internet. Communication was different, blah, 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 blah. And it never got the press and the marquee exposure that it should have, that it's getting today. He's much more popular today than he ever was back in his day.
Interesting.
Because it's such a foundational study that is so critical. And like you said, he not only did this study to show the craniofacial changes, but the reversibility of them.
Yeah. A lot of people don't know that part, that it started to revert when he stopped.
Yeah, it's a critical piece of what he found as well, So when you look at those kinds of studies, I mean, how can you argue what he found? Now, we couldn't repeat that study today because you couldn't get monkeys. They probably would never allow you to do that, even though the monkeys weren't killed. Right. But, just to get monkeys nowadays and do that would be prohibitively expensive. And what's the point? It's already been done. Yep. I mean, basically, what are you going to gain from it? But it was phenomenal. So I think that, as you come to learn over time, we talked about this with academia, if somebody has a point of view that they just completely refuse to accept, or another's point of view, they will poke every hole in it that they can. Yeah. As ridiculous and ludicrous as it seems, almost embarrassing to them that they'd make such an argument over something like that when that's a pretty black and white, clear study in terms of what was found. So you can always find people who are looking for ways to diminish other people's work for their own, personal motives. And that's a problem because, like I said, for many people, if it wasn't their idea, it can't be a good one. Yep.
Or if they've been practicing and speaking in line with an opposing idea for a long period of time, right? They refuse to acknowledge that they could be wrong.
I got to pivot here. I got to pivot, right? Yeah. This is a mistake I've been making. You never see that in medicine. Where? Show me where you see that.
Or dentistry.
I'm using that collectively, medicine. The egos in medicine are strong and they're big, and that's okay. That's what drives people to be who they are. We understand that. You wouldn't have heart transplants if you didn't have DeBakey and all those kind of things, going on. So we understand all that. But at the same time, like you said about the hormonal study, there have been errors. And it's very hard for people in medicine, dentistry collectively to admit an error and say, we got to pivot. We learned something. Yeah. It's very hard for them to do that. And so it's a shame, but it's one of the, the real albatrosses around academic medicine is that inability to change a paradigm when it needs to be changed.
very profoundly stated, and I can.
We're facing that in OSA. I mean,
yes,
like I said, with OSA, I mean, people have this concept of OSA, and it's pharyngeal collapse, pharyngeal collapse, and that's where everything is. So you got all these stimulators trying to, so they do this thing called DICE.
Yep.
You know what DICE is, right?
I do. Yep.
We're going to do sleep endoscopy, and they're trying to look at DICE. Now, DICE has a mortality, by the way. DICE is not a benign procedure. People die from DICE every year.
I didn't know that.
Oh yeah. You take a severe apneic, and you put them to sleep, and it's almost like paralyzing them, and you don't have a good team around you, people die. One of my friends in Italy, he's a big sleep guy in Italy, one of his patients died from DICE. You never forget it. I said, why the hell are you doing DICE? Oh, you have to see the collapse pattern. I said, no, you don't. Look at the article that Dr. Walker, John Walker and I wrote, which is validating the Starling resistor model.
Yeah, I know.
This model shows collapse of the pharynx is due to resistance in the nose, right? And if you change resistance in the nose, you change collapsibility of the airway. Well, no one's proven that. It's a great theory. So John and I said, you know what? Let's try to prove this thing, because if it does work, then we really know we're onto something, right? Again, more data. So we did. We took 25 kids, 25 adults. Listen how crazy this is. We did just the nasal surgery, no palate expansion in the kids, the nasal surgery that I'm talking about, in 25 kids. We got a 3D cone beam CT pre-op. We measured minimum cross-sectional pharyngeal airway, and we measured retrolingual pharyngeal volume from the hyoid bone to the hard palate, everything behind the tongue in the pharynx. We got three-dimensional structures, three-dimensional measurements, and we got a two-dimensional cross-sectional area, minimum cross-sectional area, in all the patients pre-op. We then operated on them, and 3 months later, we repeated the CT scan. And there was literally a 90-something% increase in both cross-sectional area and volume. And so we tried to get that published. And you know why they rejected the original paper? They said, now listen how stupid this is. I hate to say it, it really is stupid. They said in the 3 months between the images, the kids grew. And that was responsible for the 100% increase in the volume in cross-sectional area.
I'm glad you said that, because one of the questions I had for you was literally this concept of that kids will outgrow their airway problems, which the orthodontic community and the pediatric dental and general dental community also have parts of them that believe this. The orthodontists tend to be, I think, disproportionately slanted that way from my experience. But this concept, I hear it all the time. They'll outgrow it. There was someone on one of our social media groups that did this hot take, and they were laughing about the fact that, you know how they literally what you just said. They said, you know how my patient's airway improved? It's called puberty. They grew. So, speak to that, if you would. You are the expert on the airway side of things, not me. What is that about? And is there any validity to that concept? I should preface that by saying I understand Scammonn's curves. The lymphoid tissue does involute when you get towards adolescence. Okay, fine. But that doesn't mean, as far as I understand it, I want to hear your thoughts, that people with this extremely hypertrophic, extremely enlarged lymphoid tissue and or nasal passageway obstruction miraculously just all of a sudden become good breathers with time, right?
So let me just give you part two to what I told you about the Starling curve, the Starling study. So we said, okay, this is a ridiculous response. So let's repeat it with adults. So then we took 25 adults. We did the exact same study. And guess we found? The exact same results within percentage points of the children. Now we put both cohorts together, submitted, and they couldn't say it was because they grew, because the adults didn't grow in 3 months because they were already static. And so we finally got it published. So, but this just to show you how people will look for a way to detract you from a point, and we found a way to prove it. And so,
good for you guys.
Tremendous, significant improvement in pharyngeal volume and in cross-sectional area based on relieving the resistance in the nose. So we know that this is working. So what does that mean?
And sorry, Peter, on that too, I say to people all the time, okay, yes, I get it's a static image. I get head position can come into play, although with the lasers, it's pretty easy to line the patients up in these machines. But okay, we'll go with there could be a little variability. That being said, I think we all could agree that if you took a patient for a maxillomandibular advancement surgery and their pharyngeal volume got worse post-op, you would not be happy about it. So Right. So if that's the case, if we could agree on that, then we agree there is some validity, even though it's a static image. We can gain certain information from it, but that's another one of those things that people point to and say, oh, you can't look at volumetric analysis on a CBCT or a CT for that matter because it's a static image. You need it to be dynamic. There are numerous studies that show that you have a direct relationship there between airway patency and volumetric analysis on CBCT. Obviously, with a caveat that head position could be affecting it, or swallowing, et cetera. But you took patients and you had a pretty large cohort and you compared them and had these conclusive results in analysis that the data showed changed all of them by averages of a magnitude of 90 to 100%. And people will still try to point to it and say, oh yeah, well, that's a static image, or, oh, well, it must have been, they grew. So it's so true. You're so right.
And we did everything you said. Position was key. We had to have their head in a certain position. Everything was we had pictures of everything being exactly the same from image to, from pre to post scanning. Mm-hmm. Everything was as best possible, exactly the same with head position, all that kind of stuff. Because those are one of the commentaries. What about head position, all that kind of stuff, swallowing, you couldn't swallow, all the things that make sense.
Yep. You can control for those variables.
Exactly.
But again, the people who don't want to hear this just oh no, there's no value in CBCT because of those things. It's like, as you said so well, and I keep repeating it because it's so profound. If you want to poke holes in an argument, you will do anything to try to find something to poke a hole in.
I mean, but it wasn't like we only had like 3 people out of 25. 25 out of 25, right. 50 out of 50. Right. Everybody got better. Everybody, it wasn't even close.
Wow.
I mean, it was crazy. How can you argue that it was positioned? You think every person had an advantageous position?
Right.
I mean, come on, give me a break.
Oh,
anyway,
so true.
But it is published, so that's good.
Yeah.
Now, in terms of the growth issue that you mentioned, we see this all the time. We see it from pediatricians, not from me. We see it from pediatricians. Say, "Oh, tell the parents, the kid's going to outgrow the problem." Well, what the pediatrician is saying is true, but fallacious. So why is it true? Well, because over time, lymphoid tissue, in most, not all, but in most people, involutes. So tonsils shrink, adenoids shrink, and you get a smaller walled ring, and that's because the immune contribution from the lymphoid tissue is no longer necessary as you get older. Now, there are some caveats to that with different types of problems that go into the tonsils, something called actinomyces. When you have actinomyces in your tonsil, which is a bacteria that you can't kill with any kind of antibiotic, when you see a 15-year-old big tonsils, 30-year-old big tonsil, he's got actinomyces, guaranteed. You got to take out the tonsil. It's never going to go away. And every time you cut it open, you see actinomyces. So those people, you tell the parents, that kid's got to have his tonsils out of his, especially the kids who go to college, they got tonsils like this.
Yeah.
In college, take them out. They're never going to go away. Yep. So that's an exclusion. But otherwise, they usually shrink. Now, look at the growth chart for craniofacial growth. By age 8, 90% of the craniofacial skeleton is formed.
Thank you.
So it's too late. If you say, oh, wait till they're 15, 16, which is when the involution really maximizes, the damage is done. And I tell the parents all the time, listen, you want to wait, take that risk, because your kid is showing signs of hyperactivity right now, and could be on the fence with that, could already be hyperactive. You want to take a chance and see if that kid, because you can tell by the sleeping pattern, right? Kid's bouncing all over the bed. No one wants to sleep with the kid. The kid's getting adrenaline and cortisol up the wazoo all night long. And so you say to the parents, he might not have ADHD right now, but there are trends here, suggestions based on his history. No one knows how long it takes to develop ADHD from that exposure during the night.
Right.
How much cortisol, how much adrenaline, how many days, how many nights, what the levels are on any kid. No one measures that to know. But we know by behavior, this kid's at risk.
Yep.
And so we tell the parents, he's at risk. You take the chance, you want to take the chance, that's fine. But I can tell you this is not normal sleep patterns, right? And you got all the other history that goes with the exam and all that, but just that alone. So why would you not? I mean, it's a stupid argument. Again, I hate to use the word stupid. It's not a very academically solid argument to say they're going to outgrow the problem. They outgrow the lymphoid hypertrophy. The problem is the craniofacial growth restriction, which once you have it, that's when you have a problem for life.
Yeah.
That's when you have nasal bones that are so close together inside that, you got to do MARPs or SARPs to get that thing open if you really want to, or other things that might be necessary. Palate expansion alone, the simple way of doing it may not work. And so, why? It doesn't make any sense. Now, the other thing, Mike, a big part of this is that the pediatricians have always been gatekeepers of safety and protection of children. They won't send a kid for hernia repair unless it's going to be a strangulated hernia. I mean, they think surgeons are by all means Darth Vader.
So is that why there's the whole, no, you didn't have strep 5 times in a year, I won't send you to the ENT? Is that where that comes from?
You bet. They think that, because kids die from tonsillectomies, right? I mean, it's rare, but they do. So you go back to the following, which is, surgical intervention is a serious deal. There's no question about it. You go to a really good surgeon, and I must tell you, there aren't a lot out there. So you go to a so-so surgeon, you don't know. Because your friend said, go to Billy Smith. He did my kid's tonsils. You have no idea what's happening with Billy Smith, right? A surgeon can tell. I can look at a surgeon in 5 minutes. I'll tell you whether it's a good surgeon or not. But not everybody knows this. So pediatricians know this. They know that kids come back with problems. So they say, I don't think it's worth it. He'll outgrow it, because they don't know the surgery that I do. They have no idea what it is. And when I do have a kid who comes from such a pediatrician, and the parent then takes them back after the surgery, look how much better my kid is. It might be one kid from that practice that I see.
Right. And they'll just say, it's an anecdote.
Exactly.
Right. Yeah.
So they don't know. They don't see the whole cohort of kids. So they say, you got lucky. They don't know. So they're doing what they think is right in their heart, ethically, to protect children from unwanted outcomes. Because if you screw up a nose, for example, in surgery, it can be an irreversible problem that this kid is now screwed for a while. It might not be something you can fix. So you go to the wrong person, you get into trouble. They know that, and they see that. They just don't know who to send to. And the credentials of that person, because how would they know? They're pediatricians. They don't know.
Right. And then am I right that a lot of the ENTs, it feels like I get questions from a lot of people who follow my show, or just when I speak, they'll come up to me, and it happens, I think, almost all the time, where they say, I can't find an ENT who will actually go in and operate on these young patients, even if they get to the ENT. The ENTs look and they don't want to operate. And it's not my place to say that's the ENT's job, is to know that. I'm not obviously the one doing the surgery, and I'm not the one trained as such. It just seems to me, when you have these kids with 90% obstruction of their adenoids and they can't breathe, yes, if they're narrow as well, and when I go in and develop the arches and try to get them breathing better, sometimes you can see some shrinkage of the lymphoid tissue. But when they're that obstructive, this kid's suffocating, literally suffocating. And it's interesting.
The indications of adenoidectomy are, chronic ear infections and X numbers of, upper respiratory infections. If the kid doesn't have that number, you don't hit the target, I can't touch you yet. Got to wait till you get sick. I mean, it's stupid. Same thing with these kids with huge tonsils. They got tonsils, kissing tonsils. There's a problem. And the doctor says, well, how many infections? Kid may not get infected. He just has huge obstructive tonsils. Right.
And he's not breathing, and it's affecting him neurocognitively and behaviorally, right? And craniofacial growth.
You can't get a sleep study. You don't even need a sleep study, but you can't get one. No one takes a history. ENT doesn't know how to take a history on craniofacial growth and pediatric development. I have no idea how to do that. You guys are much better at that than the ENT guys are. So the kid's in limbo. And what's really bad is it embarrasses you guys because you see an issue, you're right, you send them there, and the ENT says, no. I got this woman I'm going to talk to later today, who's, I told you, in South Dakota. She saw 3 ENTs, and the dentist called me up after a webinar I gave about 3 weeks ago, and he said, I saw your webinar, and I know this is my patient. She has everything you said, and 3 ENTs said nothing to do. Can I send you her CT? I said, send me the CT. He sent me the CT on the internet. This woman is got everything wrong in her nose, like 18 different things wrong. And they said there was nothing wrong with her. And they had the CAT scans to look at. And so, he said, I knew it. I knew that there was something wrong with her. So, it all goes back, a lot of it, to training and expertise. And, I've trained doctors my whole life, whether they've been residents, fellows, or postgraduate guys in practice. And, it's all over the map in terms of what people learn, what their capabilities are, what their comfort levels are, etc. I always say, it's better to not harm the patient. So I think it's better they don't do anything if they don't know what they're doing.
Yeah.
Right. So no harm, no foul. Maybe they'll find someone who can help them eventually, or they'll learn about it. But, to force a doctor to do something that they don't know how to do is dangerous, right?
So what do we do? I mean, is it that it's liability? Because some of the orthodontists that I interact with will say, oh yeah, ENTs went through a phase where they were taking tonsils and adenoids out on everybody, and then they realized it wasn't doing anything, so they don't take them out on young kids because that doesn't help. Like, I've had orthodontists even just recently say that to me.
Because the tonsils and adenoids have been shown with this sleep disorder breathing, that's not the answer. It's right here between the eyes. It's the nose. We have so many kids who come in who've had their tonsils out, and their mothers say, he's still having problems. He's still got, right. Of course.
The Bhattacharya study from 2010, where they said only 27% of patients followed between 40 and 720 days post-op adenotonsillectomy had complete resolution of symptoms. And I say all the time, the etiology of sleep disordered breathing is multifactorial. And so the solution needs to be multifaceted. And then in my episode with Liz, and I told her I was going to steal it, Liz added, and oftentimes multidisciplinary. And to me, that's what you're saying. That's what gets at the crux of all of this is we're all siloed so much that we look at, the orthodontist or the dentist is looking at the mouth, right? And the ENT might just be looking at tonsils and adenoids if they don't have a rhinology background. And that's why I love getting the allergist involved, because if there's an underlying etiology of allergic rhinitis, there was a great article that just came out in September of 2025. And people talk about adenoid facies, and we've all heard that. And there are a lot of orthodontists that don't believe that's a thing, and they don't believe that that's true. Although I don't know how you couldn't believe that's true. Again, back to the Harvard studies. But and there's been multiple studies in humans as well over the decades that have shown that that's the thing. When I teach and lecture, I highlight a lot of them. But this study actually labeled something called rhinitis face. And I'm giving a lecture at a dental society meeting this week, and I'll be talking about that as well, because it's what I always show when I teach are the signs and symptoms of sleep disordered breathing that we have to be aware of. And so we're realizing that it is all related. To separate out and try to look at the nose separate from the pharyngeal airway, separate from the intraoral tongue volume and the arch shape and dimensionality of it. I mean, I don't think any of us at this point can answer this conclusively, but what are your thoughts as to why we remain so siloed, and what can we do to try to break these walls down and barriers?
Well, we're siloed because education is siloed. That's where it starts. It's that, people come out of training. I'm sure it happens in your area as well, which is why we talked about you're training young people in pediatric dentistry now, how wonderful that is. Because they come out with these dogmatic approaches to medicine. What I learned in my training, that's the way you do it. In fact, corporate America knows that. So what do? They go after the residents and try to get them to use their products, their tools, their medicines, their disposables. Because if they use it in training, they're going to use it when they get out, because they're just creatures of habit. They're going to go right to what they learn. In fellowship, same thing. Many of my fellows, they gradually say, oh, okay, where can I get this? Where'd you get this from? They want to use the same thing. I mean, that's fine. But philosophically, I say to them, listen, you have to decide. You're the future here. You guys have to be thinking about the problems I didn't solve yet. You know what they are. We're still working on them. You guys have to solve those things. Don't get stuck in what I'm teaching you today. What I'm teaching you today is what we know today. But that might be different in a month or 2 months or a year. So you have to realize it's ongoing education. We haven't solved all these different problems. Why? Because there are so many to solve. So you have to observe the patients, observe where are the problems, what are the things we haven't solved, and target them, and go after those things. And so, it's an ongoing process. There's no question about it. And it's critical for people to realize that. But unfortunately, in education, they come out with this one approach to everything. I do a product this way. I do this surgery that way. I treat this that way, this way. I mean, try to get them to move off of that is not easy at all. And it's something that we struggle with in medicine as much as you must in dentistry. And it's in all phases of medicine. You come out of a pulmonary fellowship, you come out of a pediatric residency, you come out of an anesthesia. I have guys in anesthesia who will not use an LMA, which is laryngeal mask airway, instead of an intubating endotracheal tube.
Okay. Yep.
They were never trained to use an LMA. Now, LMA has been around for 20 years, 22 years, and they still won't use it because they haven't been trained to use it. They didn't use it in residency. They were told it's dangerous not to use it. I said, I've used it for 25 years, never had 25 years, never had an airway problem. And you're telling me it's a dangerous thing. I've done probably 20,000 cases with an LMA. What are you talking about? Were you taught how to use it? Did you ever try using it? You want me to show you how we use it? They just come out with this idea in their head, and so you don't do it. You get some people who will pivot and go and try different things, of course. Otherwise, there'd be no growth and development or progress in medicine. But I tell you, it's really hard to do it.
Yeah, it's the exception. That's definitely for sure. I appreciate that explanation, and that does provide clarity. And it is interesting to see, again, as I said before, all the parallels. So before I let you go, one other topic I want to just touch on that you and I spoke a little bit about, and it's also become, it's surfaced again in some of these orthodontic study group conversations, but nocturnal enuresis. So there's certain of my colleagues who don't feel that nocturnal enuresis, bedwetting at night in children, say 7, 8, 9 years of age, is related to airway. And then they also don't feel that the orthodontist can play any role in that. Again, I say to them, I'm not here to ever tell anybody that if you go in and expand some 8-year-old with nocturnal enuresis, you're going to cure it all the time. I am going to say that if the transverse deficiency was a big part of their mouth breathing and airway compromise, and you correct that, I saw it happen all the time where the nocturnal enuresis is resolved. But to your point, as we said before, if it's the nasal passageway obstruction or the lymphoid tissue, then and there's still, with airway obstruction, you're probably not going to solve it in those children. So can you help provide a little clarity on the whole relationship between airway and nocturnal enuresis and what role we can play to improve that and help these kids?
Yeah, so that's an interesting topic. This is an example of what I said about targeting what we know and trying to solve it. So we did that with bruxism. We figured out, well, the bruxism is really from airways. Then if we correct the airway, the bruxism should go away. And we proved that does work. It's exactly worked. ADHD, if it's related to airway, if you improve the airway, does the ADHD go away? Yes, we just showed that. 60% of kids, you completely normalize their ADHD, it's gone, not even happening anymore. So, but we haven't done that with enuresis. The reason is I don't have enough kids with it. So we didn't get enough of a volume of kids with that particular symptom to study as a simple group. You may get a lot more than I ever got. I never got a lot. We got a bunch, but not enough to study. And then there's age differences, but that's okay. So what I notice about these children is, number one, of all the things they're bothered by, that was number one on their list. They don't care about anything else that they have with related to sleep disorder breathing, except, doc, when am I going to stop wetting the bed? Because I can't sleep at anybody else's house. I can't have people over my house. My brothers and sisters make fun of me. And it's just a horror life for me. I can't do this. They ask me, when I'm taking them to surgery, the first thing when they wake up and they're awake, when am I going to stop wetting the bed? I said, you got to give it a couple of weeks, but it's going to happen. But the first thing on their mind when they wake up from medicine.
Amazing.
This is one of those things that is such a touch point for these kids. They're so in tune to this. They're dialed into it because it's so disruptive in their life. So I believe it has to do with pituitary dysfunction and ADH suppression. ADH is anti-diuretic hormone. And
vasopressin, right?
Yes. Just like it does growth hormone and some other things in children. And it increases other things like cortisol and adrenaline, right? So some go up, some go down. And when you correct these kids, they eat better, they grow better, and then they stop urinating. Now, again, hasn't been studied. No one's poked kids and measured their ADH levels and all that, but it makes total sense that that's the story of what's going on. And so anecdotally, at this point, I can tell you, yes, I haven't had one kid that I've treated with enuresis that didn't resolve after nasal surgery. Not one. Now, again, do I have 45 kids? No. Unfortunately, that's why that's not a published thing right now, because they just, how do you advertise if your kid wets the bed, send them into us? And we just didn't do that. Now, could you pool with multiple practices? Yes. I guess that would be a multi-center study to do. But again, you'd have to have the same treatment, right? You'd have to have the same treatment. And that's where the problem comes in when you have a multi-center trial.
Yep.
Like you give me a drug, everyone gets the same drug, the same dose. It's much harder when you're doing this kind of multi-level surgery or whatever it might be that we're doing.
And the ethical implications too on if you feel it's having a positive benefit, you have to have a control group to conduct some sort of, it would almost have to be longitudinal or retrospective, because if you try to put a control group in, and that's where there was one article that came out recently, actually I'll send it to you, I posted that showed, it just came out, the N was 28 subjects that it showed with maxillary expansion, it significantly improved the incidence of nocturnal enuresis in these patients, and it lasted over time. And people were like, I'd really like to see a control group. And I tried to explain, how ethically are you going to create a control group for that study? And back to your point from before, if you want to poke a hole in something, you will try to find anything. But here you have a study of 28 children that all got better, significantly better, and their nocturnal enuresis resolved with intervention being, in this case, maxillary expansion. It didn't matter if it was slow or rapid. So again, it was about improving the airway patency. And I guess as you were saying that, part of me is really saddened that our institutions aren't doing this, collecting this data, that here as clinicians, we're being forced to try to assimilate this data and figure out ways to collect data, and that our institutions aren't running, in both medical and dental, big studies on these they have the patients, they have these huge cohorts that they could use and analyze this data. But as you said, many of them aren't performing the procedures which actually would be benefiting, so it doesn't happen.
Well, academic medicine is like the aircraft carrier. It barely moves. It slowly goes along. And private practice is, the PT boat that's buzzing around, zipping here and there, because you have to be competitive. You're looking for in private practice, if you don't solve a patient's problem, that's bad negative press. Everyone goes out there knows that don't go to that guy. He didn't make me better. In academic medicine, it's not the same. No. They want to do well. Don't get me wrong. It's not that they don't, but they don't have the same incentive.
Yeah.
Because they got this big support group behind them, right? They don't get a good result. Well, not everybody gets a good result. But if you don't get a good result, that's a big ding on you, right?
Yep.
And that's out there in the community. Don't go to Mike DeLuke. So private practice guys, they're cautious in that way because of that as well. But they're also very interested in getting a great result. And so they're more likely to try something new or do something different. There's also the competitive edge from a business standpoint. I'm doing something that my neighbor doesn't do, so I'm going to get more business because he doesn't do it, so they'll come to me. So that drives them also sometimes with innovation. So there's a lot of reasons why people do certain things. But again, either way you look at it, there's less of a drive in academic medicine for any of those reasons.
Yeah.
For people wanting to move, because they don't have a business need.
Right.
A business, they really don't. Yeah. And they want to do research that they want to do, that they think is important.
Right.
And if they're not into airway, they're not going to do airway research.
For sure.
I presented an article on swell body reduction, which is a great thing for airway. It's a swell body that lives on the septum. It's a venous lake. And we were looking at this thing for years. It's on every x-ray. It's on every scope you do. And it's always in the way. I'm like, what the hell? This thing is always in the way. So I decided to treat it one day. And we started this, just anecdotally, try to use some radio waves to shrink it down. By behold, lo and behold, patients loved it. They come back in, man, that thing you did is fantastic. So we did a study, and we published on 40 or 50 patients on swell body reduction and using radio waves, and the results, complications, all the stuff. We published it, but we presented it first at a meeting. So I presented at a meeting. Man, they were throwing rotten tomatoes at me. How did you have this is only 3-month follow-up. You need 2-year follow-up. This is what you're going to worry about. I'm like, guys, listen. I'm giving you some information to run with, to think about. This is something new.
Yeah.
It's great. It'll help. So now it's 10 years later. It was in 2015, published in 2015. So now it's 10 years later, and it's standard of care to do swell body reduction. Anybody with an airway issue, sleep issue, snoring issue, all of it. But no one will go back to that and say, gee, we really gave Pete a hard time.
Oh, sure. Yeah, forget it.
Come on, guys.
They're going to take credit. They're going to take credit for being the innovators. Well, I really appreciate you taking the time to come on, and the time that you spent going into this, your story, your journey, all of the points I wanted to cover, and so many of the myths that you dispelled and just help shed some light on. These are the types of conversations. When I started this platform, I really envisioned having these exact types of discussions with colleagues to try to help break some of those silos, those walls we're seeing. And maybe I have people who follow the show and follow my content who are in academia. You are in academia. I am as well. we just need to all start to come together on these topics and start to hear what one another has to say, understand the value and the power of looking at our patients and trying to help them. And you alluded to this, and I agree. I don't feel that anybody's going at this like I don't want to help these people. I just think we all have a different idea of how to get there. And some of us have more risk tolerance than others. And so we just need to be open and communicate on this. And I think we can all get to a better place. So I'll let you close it out with your thoughts on that. And if you want to let people know how they could reach you, if they would like to follow up, that would be great.
Sure. Well, again, it's been a pleasure. We need more people doing what you're doing, Mike. I mean, you're carrying the torch here. You're championing this. And I got to tell you, it's a lot of work. People don't realize it's a lot of work.
Thank you.
It really is. And we didn't have this opportunity years ago. I mean, this is wonderful. And I really enjoyed being on here. And if people want to reach me, you can use my email. It's my last name, Catalano, followed by P for Peter, the number 9, catalanop9@gmail.com. And I always respond back. And I'm willing to help anybody with questions or anything they have, because like I said, you might not get the answers that you need. And somebody say, listen, am I on the right track? Even that can help somebody feel more confident in what they're doing with their patients. But happy to help anybody that wants it.
No, I appreciate you so much and all you've done, and thank you for that and offering up yourself and your expertise continually. You don't have to do that, and I know you've had to fight a lot of fights as well. So I admire and respect that you're fighting those battles. And it's funny how we tend to find one another, those of us who are on this journey. And I thank Liz for putting us in touch, and thank you again for your help with the article that I'm working on as well. It was really great to have your input and insight into that as well.
Oh, that was all you, but thanks.
Thank you. Well, Dr. Peter Catalano, absolute pleasure. I enjoyed this so much. Thanks so much.
You're welcome. Have a great day, Mike.
You too. Bye.
Bye-bye.
Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.